In the case of Mallory Weiss bleeding, what is the best treatment? Mechanic therapy or thermic therapy, or also adrenaline, so injection therapy?
So usually Mallory Weiss tear, if it's clean and it's not actively bleeding or there's no major stigmata, so it's not actively bleeding, there's no visible vessel, or even if there's a clot, you really can leave it alone. Okay? You don't need to do anything. I would not recommend just using epinephrine alone for major stigmata, just like we don't do that with peptic ulcer bleeding, because they are at a higher likelihood to rebleed. Epinephrine is not definitive therapy. If that's the only thing you have, then you can do that. So you can treat major stigmata if you see it on a Mallory Weiss tear. And again, it's going to come down to you can use mechanical therapy, such as clips. Usually you're going to be able to use through the scope clips because those lesions are usually not chronic and fibrotic. They're pretty soft, so you can be able to close that with through the scope clips. You could, if you want to, also use contact thermal therapy, like a bipolar probe. Okay?
Thank you.
Yeah, you're welcome.
In the lower GI bleeding, it's a simple question, but when colonoscopy? Because in the daily basis, we see, at least in my center, performing many times colonoscopy only in that day or the next day. What is your opinion about that?
So it's not even my opinion. So what's currently recommended in guidelines in terms of timing of colonoscopy in patients who present with acute lower GI bleeding, the ESGE, we have our own guideline. There is a guideline also from the British Society, and there's a very recent guideline in the last year from the American College of Gastroenterology. And they all basically say the same thing in terms of timing. When I was in your stage, we used to say you needed to immediately scope these patients within 24 hours. You prep them immediately. That's no longer true. If you look at the high level of evidence studies, the randomized controlled trials, and there's at least 4, there may be 5, and there was actually a meta-analysis, there's no significant benefit in most patients to do colonoscopy within the first 24 hours. The current recommendations from guidelines is in those patients who are hemodynamically stabilized, right? You can wait and do their inpatient colonoscopy sometime within their hospital stay. So you can do it at 48 hours, you could do it at 72 hours. In patients who are not responding, they come in with acute hematochezia, they're not responding to hemodynamic resuscitation, or you're worried that they're actually having, maybe it's coming from an upper GI source. In those patients who you cannot prepare for colonoscopy and do that, they can be sent for a CT angiography immediately. Okay?
Thank you.
Only about the lower GI bleeding. From an active diverticular bleeding that is not often seen in my center. How do you prefer to treat it? Active bleeding from diverticular?
Okay, so if you have active bleeding, or sometimes you may find like a non-bleeding visible vessel there, either on the mouth or maybe deep inside, the current recommendation would be to treat that. If it's actively bleeding, you can initially inject with dilute epinephrine around the area to slow the bleeding or to stop the bleeding. What I mean by dilute epinephrine is you can give it as 1 to 10,000 or 1 to 20,000 dilution. You can inject around that area, and generally then we'll close it with a through the scope clip. Yesterday in my talk, I showed a couple other videos. There have been some case reports and case series where they've closed those types of lesions with over the scope clip. And they've even been reports of using band ligation to treat that. Now, if you're going to use band ligation or you're going to use an over the scope clip, my recommendation would be to mark that diverticulum with a through the scope clip in the area, because you need to bring your scope out, right? So you need to bring your scope out and load the band ligator or load the over the scope clip, and you may not find that diverticulum again. So you need to mark that spot, and then you can go back and treat it. I personally think that in most cases, you're going to be able to get by using a through the scope clip to treat that type of a lesion.
So you would prefer through the scope clip?
Yeah.
Easier.
Unless there's some other reason, I think my preference would be use a through the scope clip to treat that type of a bleeding lesion. Let me ask you with, let's say somebody comes in with suspected variceal bleed. What are two things that everybody should know to do before endoscopy?
Besides the medical therapy, or?
Well, yeah. What would you do in the emergency department? Somebody who comes in, they have alcoholic liver disease, they've had hematemesis. You're pretty sure they're bleeding from varices. What are the couple things for sure you want to do in addition to what we've talked about now?
The antibiotic,
right?
And the vasopressor.
Exactly.
Terlipressin in my center.
Okay, so you use terlipressin.
Yes.
Okay, so you want to put them on a vasoactive agent already while they're in the emergency department. Does everybody use terlipressin here?
Yes.
Okay, yeah, that's what we do too. And what else would you do? You said antibiotics.
Ceftriaxone.
All right, so you can give them ceftriaxone, you give them a gram of ceftriaxone, and you can, first of all, the vasoactive agent, I'm skipping back and forth. The vasoactive agent, you usually will continue if they've had variceal bleeding for anywhere from 3 to 5 days. You could do that. And the ceftriaxone, you can give them a gram once a day for usually 5 to 7 days. Okay, so that's really those are very two important things you want to do in patients who you're suspected of having a variceal bleed. Have you had any experience with treating gastric varices?
Only once, actually.
Okay. What did you use?
Cyanoacrylate.
Okay. And do you mix it with Lipiodol, or
Yes.
you do?
But actually, I want to ask you your opinion with Lipiodol or without Lipiodol.
We first of all, fortunately, it's pretty rare that we see gastric varices where I'm at. We've seen it a few times. When we've done that, we've mixed it. But there are glues that are available where you don't have to use Lipiodol, and I'm blanking on the one that I'm thinking about. It's the one I think that they use in the emergency department to treat cuts and things like that, where you don't have to use some type of an admixture that you put in with the cyanoacrylate. But we use cyanoacrylate and Lipiodol mix.
50-50.
50-50, exactly. We'll usually do 3 small syringes, 1 cc and 1 cc of each.
Okay.
And then we'll usually give anywhere from 1 to 2 cc's, maybe 3 cc's of the mixture directly into the gastric varix.
Because it's always a discussion because of the risk of embolization with Lipiodol. So
Exactly. Have you had any experience with EUS guided treatment of?
no.
No. So we've had a couple cases of that. It actually works quite well, where you can actually we'll put coils. I don't do EUS, but my colleague does. We haven't done it in the acute situation just because it's who's ever may be on call. But if we've been in a situation where you can do EUS, we do EUS. We check Doppler flows. We'll usually put in 1 or 2 coils, and then after the coils are in, you can add the cyanoacrylate. Mm-hmm. What happens is that the coils act as a scaffold, and the glue can grab onto the coils. Theoretically, it may lessen the chance of having embolization, and it may work better than just coils alone or just glue alone. And again, the data is not completely clear at this point.
Okay. Thank you.